Hello, my name is Dr. Ukiri Richard. Let's continue our podcast on basic cardiology, and today we are talking about exertional thorax pain. Let's use the case of a 73 years old patient that was sent to you on an outpatient basis with exertional thorax pain and exertional dyspnea. Apart from that, there is also some dizziness, but no syncope. The atherogenic risk factors are arterial hypertension and a dyslipidemia. The significant findings in the general body examination was an elevated blood pressure of 160 to 80 millimeters of mercury, an arrhythmic pulse from 65 per minute. There was a 3/6 systolic murmur in the right third intercostal space with addition to the carotids. There was also a 1/6 diastolic and 2/6 systolic murmur over the mitral area. After seeing this patient, you ordered for a 12 canal ECG, X-ray, chest X-ray, and echocardiography. My question is now, if you have been able to exclude an acute coronary syndrome, what are your differential diagnoses? Well, from the history and the examination findings, the presentation is very suspicious of an aortic, a high-grade aortic valve stenosis or a mitral insufficiency. So my question is now, what would you do in terms of diagnosis with this patient? Well, in laboratory tests, I will do the foot blood count, urea creatinine, electrolytes, and cardiac markers. In ECG, I will look out for signs of left ventricular hypertrophy, which I'll get through the Sokolov-Lyon index, S in V1 plus arrow in V5 or V6 to be greater than 3.5 millivolts. Also look for ST depression or negative T waves. In the chest X-ray, when you have the
Hello, my name is Dr. Ukiri Richard.
Left heart,
I'm doing this
right
podcast to
coronary congestion.
And
In
I want to
echocardiography,
tell you something
you
that
can quantify the valvular
and most people
function,
don't know about.
insufficiency, and
The question
stenosis. You
is,
can
how
also
you
check
got the power.
the cardiac structure and function.
Believe it or not,
So that's good.
It
Now I
answers
tell you,
the
you
question.
did an ECG and you saw sign
Yeah,
of
very many
with signs of left
conversions to
ventricular
IP.
hypertrophy. That means
Some
Sokolov
websites
index
even offers to do it yourself.
There are also some
guide
repolarization
to
use
how this hydrogen fuel
So,
cell
in the
can
chest
work for
X-ray,
your car.
you
And
saw the flattened
any hardware
diaphragm, which
Whether you want to
corresponds to
to
lymphoma.
The
The heart
water
was
is another matter.
enlarged
The
with
process
prominent
of
heming.
turning water into
There was aortic elongation and aortic stenosis. There was very, very undefined or poorly defined vascular signs as signs of pulmonary congestion.
Most conventional
Basal pleural effusion, bilateral, no pneumothorax,
has playing over
pulmonary infiltration,
the one
or
used the process of
necrosis.
fullexes to separate the
Also,
component
let me give you
of
the
two hydrogen
echocardiographic
molecules.
findings. The aortic
And the
valve was
oxygen.
optimally white. Ascending aorta was also
Yeah, Ukiri, hello.
the aortic valve was tricuspid, a bit thickened and strongly calcified. There was some restriction to the opening, and you have little insufficiency regurgitation. The maximum speed Vmax across the aortic valve was 5.2 meters per second, with maximum pressure gradient of 107 millimeters of mercury and mean pressure gradient of 57 millimeters of mercury. The opening surface area, according to the continuity measurement, was 0.7 square centimeter. The left ventricle was normal size in end-diastolic and end-systolic measurement. The walls were a bit thicker than normal with prominence in the septum. The systolic left ventricular function was okay. There was even tendency to hypercontractility with fractional shortening from 49%. There was no regional contractility disturbance. There was diastolic dysfunction grade 1. In the mitral valve, we could see some light mitral valve calcification, but the valves were not prominently calcified, the movement were okay, and there was just mild insufficiency, no stenosis. The cuspid valve was okay. The right ventricle to right atrial pressure gradient was 38 millimeters of mercury. I think by now you are getting to the point, to the diagnosis, which is an aortic valve stenosis. Now my question is, what is the most common etiologic cause of an aortic valve stenosis? Answer: apart from the bicuspid aortic valve and the rheumatic aortic stenosis, this acquired heart problem is usually a degenerative or calcific etiologic background with calcification or degeneration of the clapping apparatus as a complication of an inflammatory or an which is an arteriosclerotic resembling process. So in short, the most common cause is degeneration and calcification. The most manifestations are seen between the 6th and 8th decade of life. About 25% of patients above 65 years usually have some form of aortic valve sclerosis. The associations are with age, masculine sex, arterial hypertension, nicotine abuse, LDL and LPA concentration, and diabetes mellitus. Please, I would like you to tell me something about the pathophysiology and evolution of aortic valve stenosis. Okay, the development actually starts gradually and may take decades. When a hemodynamic relevant aortic valve stenosis occurs, it leads to increase in the wall tension of the left ventricle, therefore resulting in a concentric hypertrophy. As the process continues, after exhaustion of the compensatory mechanism, it leads to dilatation and function reduction caused by reduced contractility of the left ventricle or strongly raised afterload. The raised intraventricular pressure may become compensated. This, even in the absence of a coronary heart disease, may lead to a relative coronary insufficiency. So that under exertion or when there's a tachycardic rhythm disturbance, there could be subendocardial ischemia with influence on the systolic and diastolic left ventricular function. Well, it is good to know that during the latent sites, the mortality and morbidity are very few, but after development of a middle grade or a moderate stenosis, that means Vmax less than 3 meters per second, one has to expect a rapid yearly progression, which is estimated to be about 0.3 meters per second, or an elevation of the middle pressure gradient by 7 millimeters of mercury, or reduction of the opening surface area of the valve by 0.1 square centimeter per year. The resulting symptoms like angina pectoris, syncope, or heart failure change the prognosis dramatically, with a median survival rate of 2 to 3 years, and this definitely triggers the decision for a valvular intervention. So my question now is, how do you grade the stenosis, and which other diagnostics are required? Which other diagnostic measures are required? Okay, for severe aortic valve stenosis, the opening area is less than 1 square centimeter. The middle pressure gradient is more than 40 millimeters of mercury, and the jet is above 4 meters per second across the valve. So in this patient, with
my name is Dr.
hemodynamic
Richard.
parameters,
I'm giving this podcast
maximum speed across the aortic valve, which
I want to tell you
is
something
more
that
than 4
is a new
meters.
development, and most
The
people
person
know
has a severe
can I use
aortic
what?
valve
Oh
stenosis.
my God.
the systolic function
Believe it or not,
in this patient
the
with
answer to this
ventricular
question
hypertrophy
is
still remains
yeah,
intact. So that
very
I can see a
conversion
strong correlation between the clinical presentation
some
of
website
patient
even
and the
offers some good
valvular
guides to explain to you
So I have
how
a diagram
this
here that explains the flow. It's a flow diagram that tells you when
and with materials
to
can
do
any
valvular
store.
replacement in CM.
Whether you want to convert your food to
Severe
water
aortic
to
stenosis.
be run by water is an
If
matter.
it is symptomatic,
The
it
process
is
of
class
turning
1
water
A
into fuel is based
indication,
on science.
class 1
It is not like it is not known whether it is
if the patient
gas
is
mileage or not.
it's not really symptomatic, it is good to do
Conversion
a
kits are
stress
free
test. If under the stress test there are symptoms of hypotension, class 2B,
energy.
class condition of replacement. If the stress test
So
is
when we
okay,
the process of
or if the patient is not
separate the
symptomatic,
components of
we check for the left
two
ventricular
hydrogen
function.
molecules.
If the left ventricular
And
function
oxygen.
is less than 50, it's a class 1A indication.
Ukiri alone.
If the left ventricular function is normal, but there is serious calcification and rapid progression, it's a class 2B indication. But if there is no severe progression and no severe calcification and no rapid progression, then clinic follow-up is recommended. But don't forget the risk factors too. Some surgeons would like you to do a coronary angiography, or most surgeons will require a coronary angiography before the valvular operation. One was done in this patient, and the selective angiography of the left coronary artery was done, which the main stem was okay. The river had 50% stenosis in the proximal parts, and in the medial part there was a 50 to 70% stenosis. In the circumflex branch there was also a 50% stenosis. The right coronary artery had a proximal subtotal stenosis. That's the right coronary artery, RCA. The question I want to ask you now, what valve do you think would be better for this patient? Is it a mechanic or a biological valve? That's a good question. Let me run down what defines my decision of the valve to use. Your mechanical aortic valve, you will come when when the patient already had a mechanical mitral or tricuspid valve. That's a class 1 indication. If the patient is below 65 years and anticoagulation is possible, this is a class 2 indication. Well, a biological aortic valve is considered when anticoagulation is not possible. If the patient is less than 65 years and the patient decides not to have a mechanic valve after personal consideration. If the patient is above 65 years with high thromboembolic risk, here you give a biologic aortic valve, is a class 2 indication. And also for women that want to have children, this is a class 2B indication. Let me ask you another question. By the first manifestation of a left ventricular failure due to a severe aortic valve stenosis, what medications are contraindicated? Okay, that's good. ACE inhibitors actually, they lead to peripheral vasodilation, and this in the setting of a severe aortic valve stenosis will not be compensated with increase in stroke volume. So this will lead to a very severe hypotension. But recent studies have shown that a titrated or carefully dosed ACE inhibitors therapy in hypertensive blood pressure situations can be used. What are the auscultation findings in aortic stenosis? One, you have a spindle-formed murmur over the aortic valve with radiation to the carotids. You could have heaving of the apex. You could have pulsus parvus et tardus. And eventually you can have a low second half tone with paradox splitting. So now let's go back to this patient. What therapy would you suggest for him? Well, by the high-grade symptomatic presentation due to aortic valve stenosis and the coronary heart disease, the operative therapy is highly indicated, which should be actually aortic valve replacement and bypass for the coronary arteries. In fact, immediately an aortic valve becomes symptomatic, operation is usually the best. Gives the best outcome and is indicated. Even patients in very old age still profit from it. On the other hand, asymptomatic patients with severe aortic stenosis, they have good prognosis. Only 1 to 2% show rash progression, so that these patients, they need just regular clinic and echocardiographic examinations to identify rapid progression. In this case, the pressure gradient over the valve is predictive for development of symptoms. That means the higher the pressure gradient, the more likely symptoms are likely to begin. In other words, symptomatic aortic stenosis have a class 1 indication for aortic valve replacement. This should also affect patients that have high-grade aortic stenosis that are still asymptomatic, but due to one reason have indication for bypass operation or other valvular operation, they have to use this chance to get their aortic valve replacement. The so-called valvuloplasty, which is actually to widen or spreading the valve, have only palliative indication in adults, because the acute and long-term results are very bad. Okay, that's good. Thank you very much. The question now is, how do you see the prognosis after aortic valve replacement?
Hello, my name is Dr. Ukiri Richard. I'm giving this podcast to Niger people.
8%.
And I want to tell you something that is a new development and most people don't know about it.
But the operation risk,
use water,
especially in emergency operations,
believe it or not, the answer to the
association with the mortality of 10 to 15 is very high.
very many conversion kits.
There is also high
some website even offers a do-it-yourself guide to explain to you how this hydrogen fuel
New York Heart
and
if this patient also have
whether you want to
hypertension
to be run by water
coronary heart disease
process of
with ventricular
water
arrhythmias, and also associated either is not with public or severe and if they are weight. According to Society of Thoracic Surgeons, the average peri-operative mortality when you combine aortic valve replacement with the bypass operation is between 5.5 to 6.8% peri-operative. For the long-term prognosis, 10 years survival rate is 70%. 15 years survival rate 50%. If there are associated coronary heart disease and pulmonary hypertension, that means pulmonary artery pressure above 30 millimeters of mercury, the prognosis is significantly worse. The next question is, on the outpatient basis, what examination, what follow-up would you use for patient with aortic valve stenosis that don't require operation? Well, in patients with mild asymptomatic stenosis, I think the interval should be 1 year. But patients with severe asymptomatic stenosis, the interval should be 3 to 6 months. Here you take a good history, you ask for angina pectoris, dizziness, syncope, and signs of heart failure. You do echocardiography, ECG, but you do not need any endocarditis prophylaxis.